Hello, Derryfield, and welcome to Fireside Chat. I'm Lindley Schutz, Associate Head of School, and I'm here tonight with our friendly consultant, Mike Klingshirn from Fusion Cell. And the two of us are going to share with you the most recent news about how we're going to be implementing COVID protocols at Derryfield in the next bit of time. So Mike, welcome, and thank you so much for being here with us.
Yeah, thank you for having me.
Since the pandemic began, we have followed the scientific studies guided by Fusion Cell. This guidance, combined with our commitment to provide a stellar learning experience for our students, has proven successful. Our aim has been to align our adjustments with the available studies so as not to overreact or underreact. What has our experience been this year? This fall, our protective layers worked as planned, and during the New Hampshire Delta variant surge in December, we had one instance of community transmission. After winter break at January 3rd's Fireside Chat, we described our strategy for returning to school, and it was based upon the available data from December's Delta surge. We knew cases were the highest since the pandemic began, and we knew Omicron was emerging, but its effects were not yet known. Our 2-week prudent phase allowed potential COVID cases to surface while students learned from home, safely at home. We avoided having at least 56 COVID positive students, faculty, or staff on campus. Based on our understanding of the virus in New Hampshire at that time, most likely many of those cases were the Omicron variant. Our hope was that after the holidays, cases would drop because New Englanders usually don't leave their house very much in January and February, as we all know. But then studies on Omicron came in and creating a much brighter reality. How has the Omicron variant made conditions dramatically different? We're happy to say the epidemiological picture has substantially and positively changed. Omicron has changed the way we'll approach campus management. Research has come in from places that are ahead of New Hampshire in dealing with Omicron, and they're bringing us good news. In fact, it's great news. Mike, tell us about that.
Absolutely. And as always, I have a small presentation. I promise this one will be quick. It's just 20-ish slides, and I will go through it relatively quickly. So the environment that we're in, we know that there was a big spike. We know that mid-December, we saw the peak of our Delta cases. And then right as the end of December, January was starting, that big vertical straight up line right there, that was our Omicron surge. And that's exactly what we saw in other places as well. So we knew that it was going to go up, and we knew that it was going to go up fast. And we knew that cases were going to rise. And then at some point we would reach our peak and cases would start to fall. And I think that we're there right now. The big thing that I want to highlight, and this is straight from New Hampshire's COVID response, is that in the last week, there's a 38% decrease in cases, which is a huge number. So we saw a big increase, but we also are seeing now a big decrease. And if you look at the total number of deaths, and they break it out, it's very clear that the impact is felt more as you age, and it's not as condensed, and that the risk is very low when we think about kids that are school age and younger. And as we have probably heard, we remember with Delta that hospitalization rooms were unavailable, and there was talk of moving people to other states because there just wasn't enough availability of care. And so we see that big dip in the middle of the ICU numbers, and we see that dip. And as we get into these large numbers of Omicron cases, what we've seen is not as many ICU visits. And so it goes back to what the studies are telling us about this being a more mild virus, a more mild variant. And this is very good news when we see these numbers stabilizing. It means that not as many people are being hospitalized, even though there are way more people that are showing positive. And another way to look at this, New York has broken out their data. And what they wanted to highlight is not every hospitalization is due to COVID. Some people are naturally in the hospitals for other reasons, and they get a COVID test and they test positive, but they are still counted as a COVID hospitalization. And so New York's data shows that about 40% across the board, 40% are not related to COVID. So about 60% of their hospitalizations are. And so it's good to keep that perspective in mind, that other things are still happening naturally in people's lives. We still have car accidents and things that'll lend us or lead us into the ICU, whether it's a broken arm, a fracture from playing rugby. This happened to me a couple of times. And so we just want to keep a perspective that not everything is COVID. And that's part of the way that we're going to start thinking about COVID. And so the last round of tests, there were 17 COVID positive results, and that was out of 260. So the positivity rate, 6.5% of the tests came back positive. That is way lower than what we've seen in the state of New Hampshire. And it goes to show that even with extreme numbers of cases out there, well above what we've seen last year as we were operating with our masks off, the idea is that COVID is staying out. You all are doing what you need to do. You're taking those preventive measures and you're not taking unnecessary risks. And that's a huge benefit to why we're thinking about all these different restrictions that are going to be de-escalated. And so I think it's important to classify the risk. So we know that there are other diseases out there and things that we can compare COVID to. And we know what those diseases are, right? We've had them forever. So flu, as we get into the school age area, and remember that this is flu and this is about a 7-year picture for these two other diseases, so RSV and influenza. And when we're talking about these COVID numbers, these are prior to vaccinations being available. So they had the cutoff date of January of 2021. So what we're looking at here is that hospitalizations happen. They happen a little bit more frequently, but this is with previous variants. This isn't with Delta. This isn't with Omicron. So when we compare Omicron to Delta, and there are 4 pieces of statistically significant information here. We see that if you are 17 and under, if you're 11, the 5 to 11 age range, if you're in the 0 to 4 age range, your risk of hospitalization is significantly lower if you get infected with Omicron compared to Delta. And this is kind of the reason that we took some of those precautions in the first place, is because we knew Delta was not as benign as some of those previous variants. But now that we see what Omicron's doing, we see that risk is significantly lower. So 80% fewer emergency department visits, 65% fewer hospitalizations in the youngos, the young kiddos. And what we're looking at is not so statistically significant. And that's an important piece, is that when we don't have that statistical significance, we can't say that it causes fewer hospitalizations, but we can see that the vast majority of hospitalizations are on the left side of that risk, which means that it's usually approaching statistical significance, but not quite there. But the emergency department visits are vastly lower for Omicron. And I know that everyone's heard and probably read about the spike in cases and hospitalizations for kids. And the thing to remember is that hospitalizations happen, and they happen for a lot of different reasons. But when we look at this chart, we see that the vast number of hospitalizations are not in our kiddos. So red is some of your older population. The purple line approaches the 65-year-old age. Blue is 18 to 49. So it's a big group of folks there. Yellow is under 5, and that gray little blip towards the very bottom, that's your school age kids, so 5 to 18. So that rate of hospitalization is relatively low. Yes, it was a spike compared to different variants, but there are also a lot more infections. And we saw how fast it went up and how fast it's coming down. When we look at UK, they actually classified some of their risks, and they do a good job of stratifying in the UK, the difference of being hospitalized for COVID versus being hospitalized with COVID. So hospitalizations under the age of 18, it's under 1 per 100,000 for the vast majority of those age groups, which means that it's a few per million, which is great. We know that vaccines reduce the chance of hospitalizations. We know that prior infections reduce the chance of hospitalizations. But what they really classified is that even our unvaccinated folks have some of the lowest risks of hospitalizations because Omicron is not attacking younger kids, and it's not as harmful. And we know that younger age is a protective factor, and we can see that in the way that these hospitalizations go up. And we can see that if you are 39 or below, your chance of dying in the UK was very minimal. So the idea is that perspective change. So we've been dealing with this for almost 2 years now. So how do we de-escalate? How do we take away that fear that was introduced, that unknown? We didn't know what we were dealing with. This is a new virus. It's going to affect everybody. And now that we've got some pretty good studies, we know that natural immunity is going to happen. So whether you were vaccinated or not, we know that people are going to get infected. And we know that Omicron is escaping some of that vaccine immunity. And it's a protective factor. The Lancet has estimated, based on other coronaviruses and what we see in these blood serum levels, that it's protective for maybe 16 months, somewhere between 4 months and 6 years, 16 months being the best estimate right now. So it's a good protection level. And then if we look at how many people are going to be affected by Omicron, given the fact that very mild symptoms may not drive testing, and if you're asymptomatic, you're not going to be tested. Probably 50% of the American population, maybe slightly under that, will be affected by Omicron. So we're going to have a large number of people that are going to have natural immunity. We know that vaccines are great at reducing hospitalizations. We've seen this data. It's available across the board, and we just saw it on the previous slide. So the idea is, as we live with this, we're going to see variants. We're going to see variants in the future, and we're going to see things that are less severe. And we're going to see coronaviruses that are a little bit more severe. And the idea is that we pay attention to what's going on. We pay attention to the actual risk. And we shift the idea of prevention based on what the residual and actual risks are. So this is a big caveat as we talk about de-escalation, is that we're not just saying we're going to go after it. What we're saying is we're still going to protect the people that need to be protected. We're still going to keep an eye on what's going on in our population. We're still going to have some common traits of what we're doing out there. So we're getting into this endemic life, but it's important to note that endemic doesn't mean no impact. Endemic can be absolutely terrible as we look at some of the other endemic diseases like malaria, like TB. And then even in the US, we've had measles outbreaks. So we know that endemic doesn't mean that it's not impactful. It just means that we are living with it and we're going to adjust appropriately. So these are some of the common adjustments. So staying home if you're sick, even mild symptoms. And we know that Omicron is presenting more mild because it's not getting as deep in the lungs. It doesn't like to be in the lungs. It's finding better replication properties when it's in your bronchial linings. So it's more of a sore throat, maybe runny nose, cough, more so than it is that loss of smell and loss of shortness of breath. And so because of where it's living, we know that the symptoms are slightly different. And so that's why we say, even if you're mildly symptomatic, you have to stay home. We got to keep as much of this disease out as possible because you can infect other people. And it's not that you're going to hurt them. More than likely, it's going to be more of a nuisance because they're going to have to stay out for 5 days. And so the idea of toughing it out because you've got a test, or toughing it out because you want to play in that basketball game or that rugby match, it kind of goes away because you can take out a couple other people and then they're sitting on the sidelines as well. So if you do get tested, make sure you stay back until you get your results. I know that it can be lagging if you get them in some places, but just take that extra precaution. As we think about the idea of contact tracing can now be used not so much to exclude people or identify, but we think about that as where can we apply targeted testing programs so we don't have to test everybody. As we get into masks are going to become more of a protective factor for the individual. So if you're at risk, this is where we can add in KN95, those respirators, and that becomes way more protective than surgical masks, than cloth masks, and it's protective for the individual. And masking when directed. So if you do get taken out for 5 days because somebody came in when they were mildly symptomatic, and you're asymptomatic, and you come back on day 5, you're going to wear a mask from day 6 to day 10. And that's just the way that we're getting past this. And the idea is that even with a positive test and asymptomatic, we know that the chance of shedding viable virus drops to almost 0 after day 9. So everybody's body is really good at clearing this out within a 10-day mark. So if you're asymptomatic, you're probably doing a good job of fighting it off, but we're going to wear a mask for a couple of days just to make sure that we're not passing it on. And that can be a cloth mask. It can be a respirator, the N95s. It can be a surgical mask, just something to add an extra layer of protection to that one individual that's in the room. And so the question is, why go away from universal masking? And so the CDC had a study, this came out in May of 21, that there was a 21% decrease in transmission in schools that had masking. So masked students had a decrease. But when we talk about statistical significance, if we can't prove that this was not because of random chance, we can't say that masks did it. And so the idea of masks being part of a comprehensive program, that whole comprehensive program, the COVID Big Six, those non-pharmaceutical interventions, so your HVAC system, sanitation, keeping distance, the things that we've been doing for 2 years now, these all play a part. And so what they're saying is that if you have done all the right things, we can't say that masks were the reason that there was a decrease in transmission in those schools. The UK found the same thing, slightly different. Their data went all the way through January of 2022. So this is a very recent study. Once again, not statistically significant. And when we look at the recommendations of the World Health Organization, so places that the UK is probably listening to, what they're saying is that if you're in a middle school or an upper school, the mask policy should follow local guidance. So if it's mask optional in the local area, then that's really what we should probably be getting to. And the idea is that we need to prioritize learning and not overreact to something that's roughly equivalent to the impact of flu. So the transmission risks, and there's a study that just came out, and I like meta-analyses because they look at a bunch of studies and they can see the studies that have big impacts and statistical significance, and they can compare them to similar studies that didn't have those. And they can take the average. And so it kind of levels the playing field of what's really happening in real life. And so what they came up with is that across the risk strata, having a household contact that was positive for COVID is 10 times greater risk for someone becoming COVID positive than being inside of a school. So that student to student transmission is not the significant risk. So when we look at that, when we think about the masks, when we think about coming back early after that, it's really about, are you sick and is there a chance of spread? And for now, because this is what the state is saying, is when you're sick, when you have a positive test, you got to stay out. And so that's the critical piece of limiting spread. And that's a critical piece of making sure that we have appropriate numbers of staff to keep the school going, but also that we're not taking out our fellow students. But even those mild symptoms, this is the chance to take those tests to validate that we're healthy and that it's not COVID, but maybe it's the flu, maybe it's something else. So last year, we did a 2-week model between lifting restrictions. And the idea was build in a quarantine phase and make sure that those restrictions aren't adding to the disease burden. And we know what we did last year, and we know the success that we had, last year being 2021. And this year, we know that Omicron's a little faster, and we know that we can pick up on these infections, and we've got a good targeted testing program that we can employ to help lower those times as we're de-escalating. And so we've already felt some de-escalation. The idea that the A&W is opening up and that we're not seeing the COVID police yelling anymore. And so what's next? We're really looking and validating with our testing policies of when we're going to return to that mask optional, and what lunch is going to look like. And these are not, I do like this last bullet, and these slides will all be available. I'm going to send them out to everybody on the, all the Derryfield folks, so that they can make them available to parents. But it's not just Fusion Cell that's looking at what does life look like as we deal with this, but there's other entities out there. And there's another de-escalation brief, and it's really focused on schools and how we open up and why they're recommending opening up after 2 years. But a lot of their focus is on the emotional impact, the learning impacts, things that have happened when we shut down schools and when we add masks and restrictions. And so because Omicron is less impactful, but also because we have to stay out due to the state rules, we do need to keep some pieces in place. We do need to ask everybody to be the best that they can, and come in only when you're healthy. But if we can do those things, we can get back to normal operations, and we can do it safely. And that's all I got.
Mike, thank you for sharing all of that good news. And teachers and students and families are going to be so happy about those 2 changes coming up next week. It's going to be wonderful to go back into the classrooms and have masking be optional. That just opens up our exchange so differently. And then students are going to be so happy to know that they can go back to those lunch protocols of earlier in the fall, where in the upper school they can choose where they want to have lunch, as you were just saying. And if they want to find a quieter spot and go into a classroom with a smaller group, they can do that. And in the middle school, this is just such joy, because this means our 6th graders get to come into the Macinich room and join everybody for lunch. So the 6th graders will be back in the Macinich, and we'll have 5 to 6 students at a table. And a number of advisories will take turns going into the classroom so that they can all take turns being in the big room together. So those are great positive steps forward. I also just wanted to take a look at the Q&A. Thank you for those of you who have submitted questions. We're going to look both at the questions in the chat and also some questions that were submitted to us earlier. So Mike, let's get started with the questions that were submitted ahead of time. The first question is, why do we need any protocols now that Omicron is here?
Yeah, the idea is that we are learning to live with COVID. And if we just relax everything, if we say go back to what school was, the idea is that right now, currently, if you're infected, you have to stay out for 5 to 10 days. And if we relax too much and we can't tell which one of those de-escalation pieces was the cause of it, we got to add some back. And it's way easier to take things away than add them back. And so we want to make sure that we don't overburden the number of students that are out, and we don't cause impact to faculty and staff. And so what we're aiming to do with this is make sure that we take a balanced approach. And it's not because the risk is minimal, it's because when somebody is sick, they do have to stay home. And so we want to make sure that we can keep the school open and we can keep students in class.
Yeah, thank you. Our teachers who are parents of young children under 5 years old want to know the risk of their children if they bring Omicron home.
Yeah, that's a question. So we know that the risk of transmitting within the house is way greater. And I can tell you that I have a under 5-year-old, I have a 1-year-old here, and my 7-year-old brought it home. She took me out and I'm boosted, and she got him a couple days later. So we did have 3 people infected at one time in this house. My wife was the sole survivor of all the of all the infections. But what we see is that the risk, it's still there. Like there's a risk of hospitalizations with younger kiddos, but the data from South Africa is showing that even if these younger kids go into the hospital because of where COVID is living, it's not as impactful. And we see everybody across the board getting better faster. But specifically, if you're under 18, we see those days drop into the very low numbers, 3 days, usually as a median number there. And so we know that instead of 5 to 8 to 10 days, we're getting better faster, which means it's a little bit more mild. You may have to have some interventions, but the number of people requiring oxygen has dropped significantly in those populations. And the number of people requiring ventilation has dropped to very low rates compared to the other variants. So we do know that there's a risk, but it's way lower. And we hit on that. The risk of hospitalization and ER visits for the under 5-year-old population is about 1/3 of what it is for Delta. And so it's about as good as we're going to get with any variant.
That's great. That's great. If a student and their friends get Omicron at school or out of school, how will the school's response to that be different now?
Good question. So the response is going to be kind of two-pronged, right? So we're not going to require quarantine for those that were exposed. But we will ask that if a student does get Omicron, if a student is positive, that you stay home for the appropriate number of days. Excuse me. And so those days are 5 days if you're asymptomatic, and then 10 days if you're symptomatic. And there's ways of Lindley, or not Lindley, but Lainey is going to be the head of that program. So if there's any questions, she's going to be the go-to, the point of contact. So she will take and field all those and give you the appropriate, very specific for your unique case, number of days you got to stay out.
That's great. Let's see, when will our community, through vaccination and people having had Delta or Omicron, be at herd immunity?
It's hard to say. But what we see is with cases decreasing, we see that the likelihood of passing this disease is going down. With cases decreasing, the assumption is that there's fewer places for the virus to go, fewer people, that population at risk is dropping, whether it's through vaccination programs or boosting, or if it's through natural immunity. And so that's why when you see very steep increases, you typically see very steep decreases as well, because those that could get sick usually have gotten sick. And so probably by mid-February, I think is the estimate, that 50% of the population will have been exposed to COVID. At that point, we're basically at herd immunity.
Great. This next question says, we're looking forward to continuing to peel back layers. What would prevent layers from being removed?
Yeah, so layers may be prevented from being removed if we see an abnormally large number of cases happening. So if we expect that cases would be dropping in the state and we see a surge, and so 17 when we're at a peak, and if we saw cases jump to like the 50s or the 60s, that would be an idea where we may need to reevaluate some of these processes, and we may need to bring something back, whether it's distancing or keeping windows open more, or de-densifying spaces. So I think it's really the impact of what's going on in the school and the impact of what's going on in the capacity of hospitals to respond. And I think that that's the biggest shift. So it's not thinking so much about cases. We assume that cases are going to happen. We know with Omicron, they're going to be less severe for the most part. And we know that the risk of hospitalization drops significantly, especially if you're vaccinated, and especially if you've had natural immunity, prior infection. And so the risk for our younger kids is it's relatively low. The risk for adults can be offset by vaccination. It can be offset by wearing those N95s, by taking protective measures and doing some of the things that we've grown accustomed to, that social distancing, using time as a control. But mainly vaccines and KN95s are going to give you the best protection against infection.
Great. I'm going to start pulling now from the Q&A that's in the chat. One question is, could we take a look at the New Hampshire data and specifically the Derryfield data? 2 points that I have in my notes are that Derryfield's positivity rate last week was low, under 10% amidst many cases in the state, and also that there's been a 47% decrease in the number of new cases in New Hampshire. Mike, is there anything that you would want to add to that?
No, I think that for right now, that's a pretty telling statistic, knowing that infections are low within the population. And this is with us doing surveillance and knowing that we've tested 260 individuals and we've only found 17. This is not a reactive people coming in because they're symptomatic. This is us being proactive and trying to make sure that we know what our population looks like.
Is Derryfield going to continue PCR testing the students biweekly?
That will be one of our control mechanisms for peeling back stuff. But the idea is, as cases drop past a certain point, it may be once every other week, once a month. And so we can dial back on testing and do a phased de-escalation of testing. But it's really after we've taken back some of these other precautions, and it's really a testing to prove that everything is still safe and that we're not seeing an increased number of cases because we've taken away that mask requirement, or because we've gone back to a normal lunch. And so after that, it'll probably be very targeted to just individual in, say, the 8th grade tested positive. We're going to look at that classroom. We're going to pay special attention to make sure nobody is symptomatic while they're in school. And we might add in a test at some point, 3 to 5 typically is the day range, but like 3 to 5 days after an exposure. And that way we can eliminate some of those positives and break that chain of infection so that we don't have a constant every 3 days somebody testing positive. If we can eliminate that, it's going to be a good thing for the classroom.
Excellent. Another parent is asking when we might be able to step away from doing the Magnus checks in the morning.
That is a wonderful question. So I think that and that's something I'll work with Mary on. But when we think about fever as the defining factor of somebody having COVID, typically you have fever after some of the signs and symptoms. It's not usually the first thing that pops up. And so it's really a 50-50 guess on fever being a COVID factor. So we're going to be working on when to take away the Magnus checks. But the idea of the Magnus checks, the thought process behind it is it's a way to have that communication between a parent and a student and say, are you sure you are healthy enough to go into the school? And you're not just doing it because you want to take that test. And if it was my case, I'd be like, oh, we got a test today. I got to stay home. But we want to make sure that the healthiest people are coming in. And this is a way to get to that. And it's a way to help parents do it. And if we see that parents can do it without Magnus, then absolutely, we'll take it away. And I think that that's the big piece, is that we want to make sure that we still have that behavior, that conversation daily, so that everybody knows. Students know, students are educated why we need to do this. And parents need to take that last look and just say, yeah, thumbs up.
That's great. That's great. And I think too, the Magnus in conjunction with our testing, and then our just constant message about staying home when you have symptoms, helps us to make sure that people who are symptomatic are at home, so that when we're at school, we can continue to find ways to open up so that we can be safely within the realm of mask optional and other things to keep the teaching and the learning happening really well and the social emotional connection happening really well.
Yeah.
Somebody else is also asking about when students can access remotely via Zoom when studying from home, and I'll take that one. So if your student is home because of they are working through COVID, or they're waiting for testing, or they have other symptoms and they've made that good choice to stay home, the first thing to do is to email Diane Wall and Andrea Stevenson and let them know that they're going to be home. And then to remind your student, or you could do this if you want to reach out with them in the middle school, to email their parents, to email their teachers to let them know that they would like to connect with class that day via Zoom. What we want to remind everyone is if someone is not feeling well, the most important thing is to rest and get better. But if a student is feeling up to participating in class, they can email their teacher, let them know they want to connect via Zoom, and then they'll do that. If a student begins to feel well, if they've been feeling kind of punky for a few days, but then they start feeling better, again, they can reach out to their teacher a few days in and let them know they're ready to reconnect and begin participating in class and submitting work. Let's see. I think we've hit most of them, Mike.
There were a couple I wanted to touch on.
Okay.
So I saw one that says, because natural immunity is pretty durable and Omicron is less of a threat, is there anyone suggesting that people try to get exposed to Omicron? As a public health person, I will say that just because something is not a threat doesn't mean we have to do it. So I will never say try and get it, but I will point out that in real world, with cases the way that they were, with cases the way that they are, you're probably gonna have an exposure at some point in the next couple of weeks, whether you try to or not. I think the last statistic I saw is that at any one time in the last week and a half, about 12% of people that you would see at the peak, about 12% of the people that you would see in a given day had Omicron. And that would be things like a grocery store. That would be things like going out and doing your daily shopping or your normal life routines at a restaurant, whatever. So I would say don't try to get it, but it's not the end of the world if you do. And I think that that's the big shift that we're looking at, is that this isn't it's not a stigma anymore. Everyone is probably going to get it this year. If Omicron is as impactful, as if it's as contagious as we think it's going to be, you're probably at some point going to get it.
Okay. Let's see. I remember when I was little, everybody would try to get chicken pox. So I appreciate what you're saying here.
Yeah, it's not that don't do chicken pox parties, but with Omicron.
Right. What about the effects of long COVID?
Good question. So the last that I saw, and this came out of one of the documents that's linked in here, I think it's the very last one, they talk about long COVID. And the idea that the symptoms of COVID would persist for a couple weeks to a couple months to maybe a maximum of 6 months. And the data is pointing that even with influenza, we see this. We may not see it as much, but we do see influenza symptoms presenting for a while. And so it's not something that's unique to COVID. It's just something that we started talking about with COVID because it's new and it's interesting and it's not something that everyone is exposed to. And so with that, most of the stuff from COVID, from the Omicron infections, are going to be a little bit milder. So when we think about traditional long COVID, it's usually lung impacts and being tired and fatigued and not having the best like O2 saturation because of where that COVID was living. With Omicron, it's a little bit less. It may be similar, but those symptoms, what we're seeing with the long COVID is a little bit less.
Good. Another question is when students begin to take off masks, because we're going to mask optional next week, how important is distancing in the classroom?
Right. So we're still going to try to maximize distance. And the idea is that even with your mask off, we can build in a little bit of distance. Now, we don't have to go crazy with it. And we don't have to be at 10 feet or 6 feet or 5 feet. We can just try to be as much distance as possible. But the idea is that we don't need to, like, distance and masks are not critical. We can keep our healthy people in school and our symptomatic people at home, because we know that we're doing a significant risk reduction just by staying home when we're sick. And so that's the big piece that I want to hammer home. And you're going to hear me say it. I think I'll probably say it for the rest of these answers, is if you stay home when you're sick, we can. And so we can buy back some of that distance. We can buy back the risk of wearing masks. But we all have to be accountable to ourselves and to those around us. And so it's the idea of, we can use testing to validate, but we're really asking everyone to be super proactive and stay attuned to any changes in health status. Just get a test, stay home, take the day, feel better, get checked out, and just have someone give you that test.
We will remember that motto. I love that. Well, thank you so much to everyone for joining us. I think we've addressed almost all of the questions, and there are a couple that I will track down some answers to and email you directly. So thank you to everyone for joining us. And Mike, thanks so much for your time tonight.
Thank you.
Take good care. Bye.
Stay safe. Bye.